Good evening, everybody, and welcome to today's episode of Marvelous Medicine. It is purely by chance that Pallium India just celebrated its 20th anniversary just a few days ago, and it's just serendipity that we have two eminent people in the area of palliative care today with us, and the tagline is "Live Well, Die Well." I must thank Suma Balan for putting me in touch with Dr. Chitra Venkateswaran and Dr. Rajagopal for kindly accepting to be with us today despite his busy schedule. Dr. Chitra Venkateswaran is a professor in psychiatry and a senior mentor in palliative care at Believers Church Medical College Hospital, Tiruvalla. She's also the founder and director of Mehak Foundation and a consultant in psycho-oncology and palliative care in Kerala. Chitra did her MBBS from Trivandrum Medical College, MD Psychiatry from Calicut Medical College. She was a UICC Research Fellow in UK and has completed a Leadership Development Initiative Fellowship Program from Ohio. And she's also a Bernard Lowndes Scholar in Cardiovascular Health from the Harvard T.H. Chan School of Public Health in Boston. Chitra has published and presented her work at many national and international forums and has worked with national and international initiatives to promote palliative care. Her focus is on combining mental health and palliative care to reach some of the most vulnerable people in the community. Thank you, Chitra, for taking the initiative, and I request you to introduce Professor Rajagopal, though we all know he doesn't need any introduction.
Thank you very much. Thank you for this opportunity. It's a privilege and honor to introduce and interact with Dr. Rajagopal. All of us trained under him. So he's a mentor, a more like family also. My initial baby steps in palliative care was under him in Calicut. And it's always a privilege and honor to interact with him and talk to him. I also want to greet everyone who has logged in and is also watching. And specifically, I want to thank Dr. Vidya and Dr. Suma Balan for making this happen. We hope that this discussion on living well and dying well will bring us some new insights and also stimulate minds, bring some curiosity and a lot of reflection on for each one of us on our own personal as well as our professional growth. Because this discussion essentially will focus on how quality of lives of people with chronic illnesses, especially chronic illnesses, and their families can be improved. And we'll also be listening to a person who has actually proved that an exemplary model of how this can be transformed, care can be transformed in India as well as which is reflected in other countries around India as well. And also, I think you will get insights about how value-based care and value-based education is probably the need of the hour to change our discussion or conversation around how healthcare should be delivered. So I introduce to you Professor Rajagopal. Dr.M.R. Rajagopal is the director of the WHO Collaborating Center at Trivandrum. He's a founder and chairman of Pallium India and adjunct professor of global oncology, Queen's University in Canada. His initiatives to remove regulatory barriers in availability of oral morphine for pain relief have contributed to the amendment of the NDPS Act of India in 2014, a government policy on palliative care in the state of Kerala in 2008, and the Government of India's National Program for Palliative Care in 2012. The international organization Human Rights Watch honored Dr. Rajagopal with the Alison Day Forges Award at Los Angeles in November 2014. In 2017, a documentary film titled Hippocratic, 18 Experiments in Gently Shaking the World, based on Dr. Rajagopal's contribution to palliative care, was released by Moonshine Agency in Australia. I'll be sharing its link in the chat later. He was also named one of the 30 most influential leaders in hospice and palliative care by American Academy of Hospice and Palliative Medicine in 2017. In 2018, Dr. Rajagopal was honored with Padma Shri, the fourth highest civilian award given annually from the Republic of India. Dr. Rajagopal also published his memoirs called Walk with a Weary in 2023, of which I'll share the link later on the chat. Welcome, Dr. Rajagopal, sir. And let me start by asking you to just give us an outline, or maybe uh, something which all of us can learn from your journey as a physician, as a carer, especially in palliative care.
Thank you, Chitra. Very, very warm words of introduction. Thank you very much. I fear your affection for me colored the introduction, but thank you. The relevance, if you're asking for my impression of it, the relevance of palliative care based on experience. If you all think about your medical education and subsequent practice, would you agree that it was mostly based on diseases, diagnosis, treatment of diseases? The suffering that we saw around us was very visible. It was there, but we practiced a studied insensitivity. This I didn't know at that time, but looking back, we learned by our role models to concentrate on the disease and to ignore the suffering, walk away from the pain, no emotional support. It was not taught. So that's the difference. What today we expect to do is to integrate palliative care into all healthcare. Oh, that's not my opinion. This is the World Health Assembly. That's the decision-making body of World Health Organization. World Health Assembly resolution of 2014, which is being reviewed every other year, except during the COVID years. Integrate palliative care into all healthcare at all levels, primary, secondary, and tertiary, across the continuum of care, from the beginning of the suffering to the end. You see how the concept has changed. At one time, it was for the dying. Then it became for all life-threatening illnesses. Not any longer. We are talking about suffering as an integral part of all healthcare. So, Chitra, maybe that's also an opportunity to say what palliative care is to me and to you. It is mitigation of serious health-related suffering. And to remind you, that's precisely the sentence used in a 2018 ICMR bioethics document, where duty of care of a doctor is defined, mitigation of suffering, and they add, there exists no exception to this rule.
So I would like you to dwell more upon the report of the Lancet Commission on Pain and Palliative Care, which coined the term serious health-related suffering. Like you said, palliative care is always still probably perceived as something which we give during terminal or the dying stages. So people do not understand actually what palliative care is and why this this change of term was necessary, especially for a country like India. So can you dwell a bit more on why that was done, and the relevance of palliative care is not only during the terminal stage, that emphasis on that?
Thank you. As I said, Chitra, even prior to that, the World Health Assembly resolution had happened with asking for integration of palliative care. But what the Lancet Commission report of 2017 did was to lay emphasis on the suffering, to quantify it in terms of numbers, which initially seemed almost an impossible task. But depending on the number of people living with diseases and dying with diseases within 1 year, that number was arrived at. The numbers of people living with serious health-related suffering from 20 diseases which were studied, commonest, turns out to be something like 61 million in the whole world, of which, no surprise, of course, 51 million are in low and middle income countries. And as we can imagine, the magnitude of the health-related suffering is not comparable. It is unbelievably horrendous. And in India, just from 20 diseases, we have 7 million as estimated by Lancet Commission. So if you take into consideration other diseases and acute pains, etc., the number of people in serious health-related suffering should be close to 10 million. When the report was published, Dr. Richard Horton was not in the commission, but he's the editor of all Lancet group of publications. And he wrote an editorial in BMG where he said, medicine will never be the same again, just because the focus has been brought on suffering.
Okay, so I think that's a very important point that has to be, I think, reiterated again and again, because still when we work in a routine clinical practice, we do find this challenge that people refer to us only for, dying people. So palliative care is just for dying people. But to understand that palliative care is a specialty which deals with giving care from the start to the end of life, and furthermore for the family after the death of the patient. So if all the serious health-related suffering in the country has to be relieved, who should be providing care?
It's interesting that you just now brought up the phrase term specialty. It should, the specialty will continue to be there, I suppose. But can I take you to travel to utopia? Get onto a time machine and go to a land that does not exist. In the ideal world, Chitra, you and I will not have jobs as palliative care providers, because there is really nothing that we do that should not be done by every healthcare provider, every doctor, every nurse, every medical social worker. So that integration, which is a theoretical ideal, when that happens, palliative care will be provided by every single clinician. Let me bring up an example. Somebody goes to a GP or a medicine or a ENT specialist with a cold. Obviously, just a cold. You don't do anything about it on that day too. But if that doctor sees a particular anxiety on that person's face, that doctor may ask, what is it? You seem to be scared, or something like that. And then it will come out. Do you think it is something that they are afraid of? I have an examination today, which is very important for my career. And if I keep on sneezing like that, or if I feel sleepy with your medicine, how will I attend it? And then the physician's order will change from cetirizine to fexofenadine, so that the person's examination will be facilitated. So that's what we mean by integration of palliative care into all healthcare. Identification of suffering right from the beginning, and management of suffering along with the process of diagnosis and disease-specific treatment. But I think we are unlikely to become jobless, because even if that integration happens perfectly, there will still be difficult issues, like maybe a difficult pain state, maybe somebody with a complicated mental health issue. There would still be some patients whose suffering cannot be reasonably looked after by the treating physician or surgeon, where a specialist palliative care may still be necessary. So it shouldn't be palliative care specialist doing most of it. The bulk of it will be done by every healthcare provider tomorrow. And that could well be the one aspect of healthcare that is not easily taken over by artificial intelligence. Because this is more about seeing, listening, holding a hand, and trying to understand.
Yes, sir. I think you really highlighted the values which really can underlie the palliative care delivery. So when you said about the generalist palliative care and the specialist palliative care, I agree that palliative care has to be taken in by, the primary healthcare probably of India, and every doctor or every health professional, doctor, nurse, or any healthcare professional should be able to deliver. But I also think that palliative care as such, not as a specialty, but also as a philosophy and its principles, itself can cut across the healthcare fraternity and improve the care delivered, isn't it, sir? I mean, like, I think anybody like now in this audience may not be a palliative care physician, but from another specialty. But I think even if they imbibe the principles of palliative care and its philosophy, the care can transform. What do you think about that, sir?
That is an imperative, ethical imperative. We have the duty to relieve suffering. There was a time when we did not know how. But now that today, palliative care or everything, every part of it, pain management, communication, the maybe even handling the spiritual issues, all those are, we are taught how that can be done. And medical students and nursing students have that in the curriculum now. Since 2019 MBBS and since 2022 nursing students have this in the curriculum. So this integration is bound to happen, and it is our ethical responsibility because our primary duty is to mitigate suffering.
So, before we go on to the next question, I would like you to just give the people who are listening about the growth of palliative care in India, how it started, especially in Kerala, and how it has evolved and kind of now become a specialty in terms of, you have departments of palliative care in medical colleges and in institutions, in cancer institutes, and then you have the MD palliative medicine also, which has started. So just to give an idea so that we can go on to the next question.
Okay, yes, palliative medicine has grown tremendously. We have reason to believe that we are on the steep part of a growth curve finally. Palliative care came into being in Shanti Avedana Southern in Mumbai in 1985 or 86. And after 35 years, we are still nursing that infant. But now it is accepted as a specialty. There is a national program. It is part of primary care in national health policy. The law governing opioids have been amended. And the specialty is growing every year. Another 4 or 5 institutions every year are starting MD or DNB. Yes, palliative medicine has grown. But how much has palliative care access improved? The growth, is that not confined to a few cosmopolitan cities and a few major institutions? How about the person on the street? Okay, if quarter of a century back, we said that only 1% of the population has access. Well, it has grown. Now we say access is less than 4% now. That is significant growth, at least access to pain relief. Is that enough? Shouldn't the growth permeate beyond those tertiary institutions into the secondary and primary levels of care? And who will make it happen? And how long will it take at the current speed? But I am hopeful that now that the foundation has been laid, and now say, look at this, a forum on marvelous medicine, is discussing palliative medicine for the second time in 3 years. That is not a small thing. So I have reason to be optimistic that
Uh,
yeah, please
So
go.
because why I wanted to talk about the growth of palliative care is also the way in palliative care has been delivered across India, because I think it's one of the few healthcare deliveries which has been done by non-profit organizations a lot in the beginning, and then it has filtered through the institutions as well as medical colleges now and the Department of Health, especially in Kerala. So when you were talking about serious health related suffering, and that every healthcare professional has to deliver uh, at his level, palliative care at his level, what would be the role of non-profit organizations at that point? Would they survive this, or would they completely kind of become irrelevant? Because I think this is one area where non-profit organizations have really made a difference and a change in the way the healthcare delivery can be transformed.
Very important question. I think, Chitra, well, the non-government organizations will not only continue to exist, I think they will thrive, and I think they are going to have a major role in future also. I'll explain why. The non-government organizations have the limitation that its growth is confined to a few people like you, who not only have the heart and the brain for it, but also have the activism in them. And then, because your concentration is on the individual with the suffering, you you give all of your efforts and ability to this. That would ensure good quality care. Great. But that will limit coverage. For coverage, it needed to come into the government sector. Really, for coverage, now it will need to get deep into the corporate sector also. Yes. But with that, there is one risk of routinization. It is thereafter, it may not be given from the heart. Who does okay, you have that 50,000 family wellness centers in the country having palliative care. It's their job. They do it. But the heart may not be in it all the time. And therefore, the non-government organizations will continue to have the role of combining the heart and the brain and delivering quality services, which will be an obvious benchmark. If your institution shows a certain quality of care, it's imperative that some other routinized institutions also will be bound to follow.
So I also wanted you to speak about the Kerala model of palliative care, just to if people do not know about it, just a brief. How did we grow in Kerala in terms of what we say as the Kerala model of palliative care?
As you asked the question, Ashla has put something into the chat box that she brings up Asthana Declaration.
Yeah.
It will sound a bit arrogant for us Mallus to say this, but maybe the Alma Ata Declaration of 1978, 45 years back, it said for healthcare to be true healthcare, enter into a partnership with the community. And Astana Declaration 5 years back reiterated that and went one step further and said, give control over healthcare to the community. And because the pioneering Pain and Palliative Care Society in Calicut was founded, by 3 people, which included one layman. And that the initial staff was not available, and lay volunteers came in. From the inception, this idea of community participation without planning became part of it. And looking back, the advantages are tremendous, because I have this problem of my medical lens. Whatever I say, I still have my sight is colored by my training of disease-focused treatment. But the community can see that. Asthana Declaration has a sentence, I can't quote it verbatim, but it says something like, healthcare demands involvement, close involvement and collaborative engagement of food, agriculture, transport, housing, this, and this. Isn't it rather obvious? During the COVID time, as it was recovering, 2022, when the rains were very heavy in Kerala, I saw a man in his home, thatched roof, which was leaking. For 2 years, it had not been rethatched. Sitting up, holding an umbrella in his home, because the roof was leaking. He couldn't lie down. Advanced metastatic cancer. Imagine the plight. And what would we do? Dish out morphine and laxatives and other medicines. When his major problem is he is unable to lie down. And when the community comes in, that's what the Sana Declaration said. You need transportation, you need housing, everything. But can you imagine, in whether it be central or state governments, people of all these departments sitting together and planning healthcare? They are all in their insular departments, aren't they? But the community doesn't care. The community, the volunteers and a social worker, the next day brought a large tarpaulin sheet and pulled it over the roof. The man could lie down. And that was the most important part of healthcare there. This can happen only with participation of the community who are there. I challenge everybody. Can there be any community anywhere where there are no people who get some pleasure out of helping others? They are there. But we do not allow them in. We do not empower their entry into healthcare. We do not empower them to understand care. So what happened in Kerala was this community participation evolving first in Calicut, next year in Perinthalmanna, the year after in Manjeri, and then it just grew. People saw the beauty of it. So essentially, it's about community participation. After with the non-government organizations, of which there are more than 200 registered and 200 odd informal organizations in the state of Kerala. And obviously, that had its impact. It became so popular that the government, the first time we submitted a proposal, they did not even look at it. But after some 15 years, they embraced it. That's a government policy. And at least in theory, the government and community organizations are supposed to work together.
Yes, so I think to the question that, on Astana Declaration, that whether it is really realistic that we can actually think of giving control over healthcare to the community, I think you are saying that it is possible and it has been shown in Kerala, isn't it?
It has not only been shown in Kerala, but Dr. Libby Solno, a British doctor who stayed for a couple of years, 2 or 3 years in Calicut, went back home, and 30 counties have palliative care in in and around London with the participation of the community. Only this year, 2023, in Kingston in Canada, it's an organization for cancer. It's a department for cancer alone. They started community participation. They are training communities. It's happening in Canada. To some extent, it's happening in some parts of Australia. It's growing slowly.
I think
I agree.
that's great to know that the people are modeling on us also. Sometimes usually we model on something which comes in the West, and so it's good to see that some aspects of our care is also filtering through other parts of the world globally. So, what seems to be the barriers to community participation?
We the healthcare professionals and the fear. See, management people talk about resistance to change. Resistance to change involves fear. My God, how are we going to handle this? I don't know. This is not what was taught to me. And when you are afraid, you are not very sensible. Fear clouds the mind. And very often there is also anger. How can you criticize the healthcare system? Do you think everybody else is a fool? That kind of angry responses come. So it's only expected that the growth will be limited because professionals find it difficult to change. Remember, that means we are giving up a bit of the authority. The volunteers come in. They are not going to be silent spectators. They will question us. Hey, wait a minute, sir. Wait a minute, madam. Why is it that those people are not prioritized? The man can hardly stand. He needs to come in first. So we will be questioned, and we will have to accept that and give control, at least in part, to them. Of course, they need to be educated and empowered.
I'm just going to the chat for a minute to see if some questions have come up so that we can take at least one question now and then get on to the other questions. So this is about, I'm just taking the first one I saw. I think there are ones which came before this also. I'm taking this because this was also to do with what we have been discussing now about community participation. So does home healthcare for the immobile aged come under palliative care? That's one question. This can be required for years and paid caregivers are inadequately trained or unaffordable. Can it be brought under insurance policy? So there are three parts to the question. One is, does home healthcare for immobile aged come under palliative care? Second is, this has to be a long-term care and paid caregivers are inadequately trained or unaffordable. So does palliative care offer an example or a change in the way it can be done? And can this be bought under insurance policy?
The last question, answer to the last question, I really don't know. But I'll start with something that I think I can answer. The first one. What are we doing? What's our focus? What is palliative care? We said it's mitigation of serious health-related suffering. An immobile person in a bed, is that person having serious health-related suffering? Well, if yes, and therefore it has to. The fact that it is not included in a Euro-American country shouldn't bother us. If our people are suffering, we should be taking care of this. From the beginning in 1990s, early 1990s, we have included people with paraplegia and hemiplegia among the patients that we look after, because they were suffering. Does everybody really know what happens to the typical spinal injury patient in our country if they are poor? Their spine is fixed. There's an MRI prior to that and MRI after that, with which the family finances are completely lost. They are in a debt trap. And after fixing the spine with that steel rod and indwelling catheter, the person is sent home. And there is very little rehabilitation, practically none to most of them, except to a tiny minority. They stay there. Their pressure sores get deeper and deeper. The urinary infections become gradually worse. And after some 11 years, oh, why am I saying 11? I'm just making up a number. After a long time, they die horrible deaths. That doesn't happen in a Euro-American country. There they are rehabilitated and you see the person in an electric wheelchair in the supermarket doing his or her own shopping. So we shouldn't be biased because it is not included in palliative care in that country. So to the doctor who asked this question, my answer is absolutely yes. We shouldn't be handcuffed by Western definitions or practices. If our people are suffering, we should be giving care. And yes, it can be required for years. Paid caregivers. These paid caregivers have an elderly person lying in their own home receiving no care. There are paid caregivers now because of the poverty in the country. What happens in their own homes? So here, the long-term solution is both the government and the civil society should be able to see the problem. Chitra in Tiruvalla and I in Trivandrum are comfortable looking after the patients who come to us, empowering them, sending them back home. And if they do not have a home or anybody to look after them, then we find a good long stay place and send them because we have the connections. What about people whom we don't see? The tens of thousands. They die, live miserable lives, they die miserable deaths. So, what is required is certainly for the social security system to evolve. In every taluk, there should be at least one long stay home, staffed, funded, who should be able to look after people who cannot get care at home. And the final question for which I don't know the answer, my instinct tells me no. That's not the answer. Because look at the two models of healthcare in Euro-American countries. Europe, you pay through taxes through your nose and you have the care within the government system. USA, insurance. And what's the result? 20% of people at least are filtered through. They get zero care. Even the care that is given in nursing homes is questionable. And USA spends close to 20% of GDP on healthcare, and still that's the result. So if you ask me, that's a model that has failed globally. The successful one is the public healthcare system being strengthened. I hope we'll go that way.
So as a continuation, Dr. Alka Kapoor has said, I mean, since we were discussing elderly, a lot of elderly, I was also going to mention that because we do a lot of home visits for people, elderly people, because this was about aged people with dementia, with end-stage dementia, with progressive dementia. So a lot of elderly with end-stage dementia being cared for at home, but they have rice tube feeding for years till they succumb to aspiration pneumonia or decubitus ulcers. Is it not extending their suffering, and why are physicians doing this? This, I think, a very pertinent question about, when we do home visits, we do see people and, with these rice tubes and bed sores. And like you said, the local team actually takes care of this. So this is relevant to discuss about, why do you need rice tube feeding for such a patient? Are we actually extending their suffering? It's also an ethical question.
Listen, I don't know which one of you is going to look after me when my time comes. I am giving you a warning, whether it's dementia or something else. If you put me on aggressive life support measures in an incurable context when I have no reasonable chance of restoration of reasonable quality of life, what you would be doing is just prolonging and intensifying my suffering. And my threat is, if you do that to me, I am going to come back from there and haunt you. Dr. Alka, this is very important. We have been inadequate, inefficient. We have not given this the time or attention that it deserves. And the Supreme Court of India, though it gave a very good verdict in other ways, calls withdrawal of support passive euthanasia. My God, that is such a joke, cruel joke. So, Dr. Alka, we haven't done anywhere near enough advanced directives in our society. The Supreme Court has laid down directions. Now, I have prepared mine. I have, a gazetted officer sign is enough after the 2023 revision judgment. So I have it. But the most important part of the advanced directive is not preparing the document and signing it. It is getting the family to accept it. They have to be schooled in the science of resisting the temptation from hospitals to push me into the intensive care unit. That's hard for the family. It took time for me, but I talked to my wife, I talked to my two sons. So one of them took some time to digest it. Eventually, they agreed. That's the most important part of advanced directives. But nevertheless, I would recommend that all of us do it on our Palliative India website under resources. You will find the format. Prepare the advanced directive. Get it countersigned by a gazetted officer. Keep copies with your loved ones and make sure that whenever any accident happens or whatever you do, you take it with you to the hospital.
And I think also we should also do this, speak about this to the patients that we take care of, like in a very simple way, communicate with them and explain to them and point out the need or not the need of the right tube feeding or whatever is actually extending their life and not actually contributing the quality of life. I think that that is also an important point that we should learn from this. So there are many important questions on the chat, but before that, I would like you to also speak about Pallium India for a bit in terms of what does Pallium India do in different domains of palliative care. And once we talk about that, then I'll also ask you about how people can reach out to Pallium India for any support or education.
Thank you. Our objective is to collaborate and together with anybody who is willing to collaborate to work towards relieving the serious health-related suffering of that 7 to 10 million people. That may sound audacious. We don't mean to say that we are to do it, but it is our model is we call it DEF: demonstrate, educate, and facilitate. We demonstrate palliative care delivery like many of us do, many organizations do, with a certain quality and certain standards in our home institution. We educate professionals both with physical as well as more with virtual courses every year, a few thousands. That is vitally important. And we facilitate we facilitate by faculty development programs. Whatever is in the curriculum has to be taught to medical and nursing students We facilitate that, and we facilitate government policies and programs. Our teams, we have regional coordinators working in various parts of the country, working with the national health missions of each state, and also with palliative care pioneers. That is what we do: demonstrate, educate, facilitate, and collaboration. It all happens with collaboration. No one can do it alone in India.
I would also like you to speak a bit on palliative care for children. I'm sure that there are, professionals working with children in this group. So, in what way can palliative care also extend to that group, the vulnerable population of children? In what range of people, and what do we address in them?
This is a sad situation. Earlier, I said that by an estimate, access to pain relief in India is estimated to be less than 4%. We all love children so much, but we are very cruel to them. Less than 1% of children get any pain relief for palliative care. And friends in Hyderabad, Dr. Sudha Sinha did a study and published it a few years back. She found that in the case of children with advanced cancer, 50% of them of the children who died, had chemotherapy flowing in the last week of life. More than 75% had chemotherapy in the last month of life. How cruel is that? Because we love children so much, the parents want to keep trying again and again. And if 3 oncologists have said no more chemotherapy, they find a 4th one who is willing to do it. So it's a combination of both the pressure from families out of love, out of a selfish kind of love, who are unable to think, oh, the poor thing must be suffering more. Instead of that, they think, I can't let my child go. And the other part is a complicity on the part of the healthcare professionals, and a lack of palliative care education. And even generalist palliative care trained people are scared to handle children, and therefore it doesn't happen. It's a sad, sad, sad situation.
So, you have been working for opioid availability for years, and you have influenced the policies also. So, how has the opioid use improved in terms of doctors using it? Because often people look at morphine with a great deal of suspicion and hesitation in prescribing. So, how do you think that has changed over the years?
It has
Has
not
it changed,
changed.
and how?
It has not changed much over the years. The progress has been very, very slow. That morphine, stigma of morphine, the fear of morphine, because it's something unknown, that still persists. And when you and I say that it is one of the safest medicines that we have used, we are not believed. The law has been changed. The law has to be implemented by states. In the vast majority of states, now it has been implemented. Even this year, we did opioid availability workshops where the drug controllers and his officials, the healthcare managers and professionals sit together, and we discuss the rules, how it is to be implemented, etc. So even tomorrow we are doing one for Delhi. So this happens. The major gap is in inadequate education of professionals. And maybe even when they have been trained, they go and ask pharmacy, hey, let us get some morphine. And the hospital has to develop a new system, oral morphine. And therefore, the things get postponed. So it takes persistence to make it happen. I wish we had better news to share. But compared to 1998, in 23, though there has been significant growth from about 18 kilos to close to 500 kilograms consumed in the country, the quantity that is estimated to be required is something like 16,000 plus kilograms. So it is still very poor, but things are improving.
I'll start again with a few questions that came in. First question that came in today is that, is palliative care different from end-of-life care or comfort care?
Comfort care is a loose word. I mean, it is what you meaning you give to it. Yes, it is comfort care. If you treat physical, social, mental, and spiritual suffering, you are more comfortable. If you are using it in that way, it's fine. But it also involves the science, the brain and the heart coming together. But what I'll emphatically say that it is not only end-of-life care. It is not only end-of-life care. Listen, when my time comes, whether it is cancer or dementia or something else, why should I suffer through 18 months of treatment without getting pain relief or symptom control or some emotional support? And then in the last 1 month, everybody comes over giving tender, loving care. Where's the sense in okay, that is important. But every single principle of palliative care has to be applied from the time the suffering starts.
But is there something specific for end-of-life care that we do in palliative care? Like, what are the specific things that palliative care does for end-of-life care?
So I said that it has to be combined with disease-specific treatment. At the end of life, most of the time, in the majority of situations, the disease-specific treatment assumes much less important. True, even then a palliative radiotherapy may be necessary for a bony metastasis in the ribs. True, but for the vast majority, disease-specific treatment stops. You do not puncture the person every day for a fresh blood sample. You do not keep pushing in atorvastatin at that time. The emphasis is now only on physical, emotional, and social comfort. That's the time when nobody should be isolated, when the family should be around, the time when a kiss on the cheek becomes vitally important. But all that is possible. Only the symptoms have been adequately controlled. If the person is rolling in pain, naturally that social contacts are meaningless. So physically comfortable, emotionally accepting of the inevitable, saying the final goodbyes, giving love, receiving love. And when we facilitate that, we are giving end-of-life care. And as a former intensivist, still, I recognizing the value of intensive care, I would still say the ICU is the last place in the list of places where death should happen when you have a choice.
Another question from Dr. Vidya Mohanra. Cancer hospitals have mushroomed in the private sector. Given the gap in supply and demand, are we likely to see a spurt in private palliative care?
Many of you may know that, have a better answer than I. But one of the problems that I understand is the private healthcare in India is not regulated. True, there is a national accreditation board which is not mandatory, and even if it is there, to me, what seems important are the processes written in the files and kept in the cupboards. Nobody checking what is actually being practiced. But I think it is going to start more and more with people, Americans of Indian origin and Britishers of Indian origin are coming back and demanding palliative care. They come and ask, do you use a syringe driver? I've seen this actually happen. Do you have a syringe driver if necessary for my mom to be given a morphine infusion? And if it is not there, they go elsewhere. But that revolution has not happened yet. We are now working with one of our doctors for a period of 6 months, stationed in a corporate hospital in Trivandrum, integrating this palliative care. I know that to a significant extent, integration of palliative care in the intensive care unit has happened in KMC Manipal. So there must be many other places it's happening, but we are not there yet. It will happen. It's happening. There's a question. Will the income to the hospital drop if proper palliative care comes in? Therefore, would that not be a deterrent? There may be value in it. But I am sure some imaginative manager will see how much of goodwill comes out of palliative care. And that's valuable for the hospital.
Dr. Alka Kapoor's first question was, is hospice care available to patients and families in India?
To a tiny, tiny, tiny minority. Very little. It is necessary. Now that we are becoming no more nuclear families, it has to grow tremendously, but it is expensive. Hospices are expensive. Hospices in the UK several have closed down. And unlike unlike outpatient care or home visits, inpatient hospices are much more expensive.
Is the concept of palliative care integrated into oncology training in India? Kumar is asking.
It is integrated at the moment only to undergraduate medical and nursing curriculum, not to specialties. Individual institutions do it. I know that some cancer hospital, like Tata or All-India Institute in Delhi, they have the oncology residents rotating through palliative care, but that's not at the national level.
So Dr. Jimmy Matthew has three big questions. So curative medicine seems to be competing with palliative care in India, and curative treatment seems to be winning. The patients are losing when the benefits of further curative treatment are small and costs are high. I think you already mentioned that in terms of the end of life care, but do you want to say something more?
No, the very fact that Dr. Jimmy Matthew, a super specialist doctor, a plastic surgeon, is asking this question is so heartwarming. That's not a question, it's a statement. I agree. Yes, that seems to be happening. But that has to change. And who will change it? The public will change it. Maybe we need more of health education to the public. But we also have a responsibility. We will advocate for it. And then palliative treatment will get its proper place. But right now, I totally agree with Jimmy. It is unreasonable care.
Yeah, so he says that the only way out is to have Indian guidelines for limits to curative treatment depending on cost benefit. What can be done for that?
Would Jimmy or anybody attending to this, Puneet, anybody answer this question? The Indian guidelines, Jimmy, what do guidelines matter in this country? Those are things that say, for example, in the National Accreditation Board, one of the requirements is that they should have a proper end-of-life care policy. Great, you create a policy. And when they come for inspection after 2 years, you take it out of the cupboard and show it to them. So the lack of regulation of private healthcare in our country is the main reason why guidelines may not get practiced. Jimmy, you have an answer yourself?
I mean, I'm not sure. I'll try. I mean, I just asked that question because I thought that we are actually trying to see what does an aggressive treatment of, say, any cancer or anything mean, because we are basically following an American guideline or or a European guideline, which as we know has got a law of diminishing returns. So initially when we treat, okay, these are the treatments and they are very sensible, very cost benefit. But as you escalate, as our hopes go, I mean, as the disease progresses, the patient is not, fortunate enough to get a cure or a remission. Then, when as it escalates, the benefit seems to come down and the suffering seems to go up. So this is a universal thing about modern medicine. I mean, our medical treatment. But in India, it's especially acute because patients are paying out of their pocket, and at no point are anybody, and see, it is impossible for the clinician to put a brake on it, even if he's properly motivated, and many a time he's not really motivated, because obviously the benefits are when you step up the curative mode of treatment. And I thought the first step was to bring out resource specific guidelines in every specialty for every large disease, so that it should include, a committee should include a person, say a district hospital or a community taluk hospital specialist, to come in and say, okay, these should be the guidelines, so it should be done here, and these are the minimum guidelines. If you do this, at least legally, you have done everything possible. If that is possible, I'm just thinking, that's all.
Thank you. Yes, I mean, even if it is not followed, guidelines will be good. There's no doubt about it. How much of it will be followed is another thing. You mentioned the word legally. That's a big word in India. It's very difficult to enact a law. When we try to get that law changed about morphine, then we discovered that every session, somewhere close to 250 items of legislation get tabled on the parliament. Only a tiny minority get passed. So passing a law in our country is hard. But very often when there is no law, you go by a Supreme Court verdict. Or the Supreme Court, the court will go by statutory bodies' decisions. Even the National Medical Commission having well laid out guidelines would still be valuable. But Jimmy and everybody, here is a basic issue. It has got into the curriculum now, but we were not taught how to communicate any news. We did it by instinct. It was not mandatory for us to learn it, and very often we say meaningless things to patients. So the lack of ability to communicate a bad news is a hindrance. The numbers are a hindrance also. Communication takes time. We cannot just go to a person abruptly and say, okay, I have only 2 minutes, but let me tell you that he's going to die within a short period of time. And you can't do that. That's cruel. That's unethical. So here is a problem. Communication training should become part. It has become part of medical education, but who is going to teach them? So how do we bring it as part of our continued medical education? And how do we practice it? Even if we decide that we will not inflict costly, expensive treatment on them, when you don't know how to communicate and when you don't have the time to communicate, the easier thing is to give another course of chemotherapy. And who checks the economic burden and what they can afford? Our hospitals do not have medical social workers or anybody going into that kind of thing most of the time. But the problem that Dr. Jimmy Matthew has brought out, and the solution that he has offered, like creating guidelines, is something that we all should start thinking about. It will be a step-by-step thing. It took us 19 years to get the law changed about morphine. Okay, it got done. It may take 25 years, but a long-term planning is necessary. I totally agree.
He has also a question on advanced directives, but before that, I'll go to one question because we're talking about the economic effect, the cost. So Dr. Venkatesh Natarajan has mentioned that social economic conditions of living is inextricably entwined with healthcare suffering or the lack of it? How can we separate the latter without addressing the former, that is the economic conditions?
Sorry, Chitra, can you repeat the question?
Social economic conditions of living is entwined with healthcare suffering. How can we separate suffering without? How can we separate this together, suffering and the economic cost? Palliation also has its economic cost. So he's asking about the.
You can't be separated, because health is physical, by definition, is physical, social, and mental well-being. It's not a question of separating it. It's a question of we not bothering about it and we not assessing it today. Once we accept our responsibility to assess the economic situation of the patient and family, we will be able to guide them appropriately. And it takes time. I mean, like asking for decisions now. Okay, this costs so much, this costs so much, this costs only this much. What do you want? Very often the question is asked like the waiter handing out a menu and asking people to choose between matar paneer and aloo gobi. That doesn't make sense. People need time. So the social situation is part of the healthcare, part of health. And unfortunately, the problem, do you know the magnitude? 2015 publication, BMJ. 55 million Indians are impoverished in 1 year by catastrophic health expenditure. That's more than 4% of our population. And we call it healthcare. When we are destroying the health of these 55 million people, this is a reality. And palliative care also has a cost. But what are we comparing it with? In its absence, it's only a small minority of poor people who will be taken home to receive nothing at all. It is very often palliative care or disease-specific treatment. So it's going to be a huge expense versus a smaller expense. And secondly, I mean, at least in Kerala, these 400 odd organizations take it upon themselves to raise money from the community and provide free treatment to poor people. That's the way it should be.
Do anybody want to continue on that aspect? Or shall I go to the next question? So Dr. Venkatesh Natarajan asks, do people culturally accept the idea of futility of further care and embrace end-of-life care? Because he says that initiating a conversation about end-of-life care and futility immediately is met with anger, and often the doctor is accused of not trying enough. People leave such doctors who are honest about futility of medical treatment and propose palliative consultation, especially in private practice.
Now, doctor, in palliative care, I am sure Chitra would be agreeing with this. When we do a 6 weeks course, roughly 1/3 time is spent only on communication. What not to do, what to do, listening more than speaking, trying to get to know the person, trying to get to know the family, and then finding out whether they are ready to know, and then giving out the truth in small bolus doses, not the whole thing like a bombshell. That takes time, but that's worth it. Most people are initially in denial of the reality. But most of the time, Dr. Venkatesh, we are able to get there. Okay, some people will continue to be in denial. That will be a minority. But do visit Chitra or our institution. You will see how not only we teach communicating bad news, but how we actually practice it. So most of the time, after all, most people are sensible. They are emotional creatures. The initial reaction will be, I don't care how much it takes, save my mother. But that's the initial reaction. And we do not expect a decision within 6 hours. we'll meet them again the next day. And this is not all done by busy doctors, not necessarily. We have medical social workers and trained volunteers also contributing to this, to sit down and listen.
Someone, I don't know the name, his name is Pharmacology, says that I've seen a pediatric girl with end-stage renal disease, secondary to atypical hemolytic uremic syndrome, venipunctured many times a day just for IV cannulation without any beneficial treatment objective, and died after a month of suffering. How to enroll a renal failure patient into palliative care when he or she is in the impossible place in the renal transplant recipient list awaiting donor? Suffering is horrible.
This is very sad, no doubt. But compared to many, at least some initiatives in palliative care for renal diseases, not only done by palliative care people, but initiated by nephrologists, is happening in our country. Nephroplus is an organization, there must be many others, organization that takes care of, when they give the counseling about dialysis and renal transplantation, they also bring up the possibility of conservative renal support, conservative therapy. That's the next option. It's also an option. They are not forced into choosing between transplantation and dialysis and nothing else. They are given the option of conservative management also, which means supportive care. And when it is going to take time to convince everybody to follow this, but fortunately in neurology and nephrology, this initiative in palliative care seems to be happening to a lesser extent in pulmonology also. So many doctors are getting trained and incorporating this into their work. But
I think,
my heart goes
yeah,
out to that child who is made to suffer like that. And that happens, unfortunately, all over the country.
I think Department of Palliative Medicine in Kasturba Medical College, Manipal, actually has taken a lead initiative in training doctors for integration of palliative care into nephrology. I think they have come out with certain evidence also. It would be worth, I can share some if to Dr. Vidya Mohanram, and then she can share also further too. So there's a lot of work being done, like sir said, with neurology as well as nephrology, and it has seemed to be really growing. But there's another question from Dr. Venkatesh Natarajan, which I will quickly answer to, sir. It's because on communication. He asked whether is transference a problem in palliative care? Is it possible to be rational and one is so close to suffering? I think in palliative care, there's a lot of emphasis in training in communication skills. And then we are learned to be empathetic, but also maintain the boundaries. So, I mean, I admit that we see a lot of morbidity as well as we see dying, we see a lot of suffering. But then it's a team effort. So it's not only the doctor who's communicating, but you have the support of the nurse, you have the support of a social worker or a psychologist. So it's a team which is doing this job. So the burden is also shared by the team. So transparent, of course, is some people, there is some overlap and emotional boundaries are lost, but then the team recognizes that and the person also recognizes there is acute awareness about these issues in terms of communication, and we take care of that. But we have been able to really take care of people who are suffering, especially at end of life. So it is also the training and the practice and the supervision that helps us do this. So I'm just going to actually ask you a question and then open it for discussion. I'll just ask you one question about what would be one key message from your book, Walk with Very, that you would want to share with this group. And after that, I'll just open for questions verbally from the audience.
We have to make healthcare. Healthcare today is not healthcare. Healthcare today is treatment of diagnosis and treatment of diseases. We define health in one way and bury it and do not bother about what it means. It is physical, social, and mental well-being. And till we are able to look after that, we are not going to improve quality of life. But thank you for bringing up the book and the discussion. Certainly the questions, but that one issue of advanced directive was asked by
Yes.
3 different people. I just saw Jimmy's question also.
Yes, sir.
Can I take a couple of minutes to bring out the current legal position about that?
Dr. Vidya, can you speak about
Please,
that?
sir, please, sir. I was actually going to come back to that because
Okay.
not just not just the advanced directive provision, which of course, like you said, it has been made easier that it's you don't have to go to the district magistrates, and it is enough to get a gazette officer to sign. But the first part of Jimmy's question, I was going to come. So please go ahead with the legal question first, and then we'll discuss the a problem of ending pointless expensive care in the private sector.
India does not have a law covering end of life. In the absence of law, a Supreme Court verdict becomes practically what will be followed in the absence of law. The moment Parliament enacts something, that will become invalid. But as of now, okay, if the three-member court has ordered something and another 5-member bench orders something else, the 5-member bench's decision holds. So the 2018 verdict from a 5-member bench at the Supreme Court came out with the guidance for end of life, and that was fortunately revised in 2023. So for all practical purposes, that would be legally valid and binding. Advanced directives. It is there. I mean, like the Supreme Court has said that. How many people actually know? Who knows about it? Nobody does. And hence, I don't know the answer. It is not the legal position that's a joke, Jimmy. The legal position, except for a slight inconsistency, is reasonably okay after 2023 verdict. If you are to withhold life support, there is absolutely no problem. Advanced directives, according to that Supreme Court, are valid and legally binding. But any sensible doctor would know that dead people do not go to court. Living families go to court. So even if advanced directives are very clear, if the family members object, doctors would tend to go by what the family says. I mean, why should we run into needless trouble? Which is why discussion with the family and agreement with the family is essential. So, unfortunately, once somebody is on a life support system, withdrawing becomes a bit of a problem because now it will need 2 committees, one appointed, and both are 3-member committees of specialists, one appointed by the hospital and one with an external 2-member board. This process will take about 5 days. So, and again, the lawyers say if the doctors and the family, immediate relatives, are clear that this is what is medically indicated and acceptable to the family, then again there is no problem. The problem arises when there is conflict within the family. When everything is resolved and then the son from California or the daughter from Dubai comes back and the whole process starts all again. So there are issues, but things are not as bad as they were till last year. In short, advanced directives are valid and legally binding, but the family's position is practically important.
I think I have almost brought in all the questions that came on chat. Somebody asked about opioid laws in India, and I've directed them to Palliative website, sir. So I'll just open, let the audience can ask questions, whatever. Someone was mentioning about integration of palliative care in ICU units, sir. ICU.
Yeah, so very good guidelines are there. If you search for Blue Maple document from Manipal or ISCCM guidelines, Indian Society for Critical Care Medicine guidelines, both are very valuable guidelines. ISCCM guidelines and Blue Maple document.
Dr. Vidya,
There
we
was a
can't hear
question
you.
from Dr. Alka Kapoor about rice tube feeding in
We
end-stage
answered
dementia.
that, sir. We answered that.
Okay,
We
okay,
answered.
okay.
Yeah. She speaks about some hospice care in USA, which I didn't bring up. I brought the other questions up. Dr. Vidya?
Like you mentioned, sir, the main problem is withdrawal of advanced care because sometimes it takes time. Like you said, this advanced directive came in recently, and then there were so many impediments, and now it has been eased. So, given all that, it's a very minority, hardly 1% of patients who land up even in a sort of private tertiary care are likely to be having that advanced directive, or even some kind of family decision made in advance, even if there's no written thing. So most of the organizations, even despite Indian Society of Critical Care Medicine guidelines being fairly clear and enough evidence that that is being practiced by many intensive care units across the country, and none of them have got into any legal problem while when they went through the proper process. Even then, there is a fear among intensivists as well as some kind of directives from the hospital authority, especially in the private, saying that no, you cannot, it's not legal to say do not intubate, or it's not legal to say do not resuscitate. And even if you're doing nothing, when in the end comes, you're supposed to have, when there's a cardiac arrest, you're supposed to write that, you tried resuscitation and it failed. Like you said, it all comes down to the initial wording of passive euthanasia, which has been wrongly used. So, how do we overcome that barrier?
Uh, Dr. Vidya, we need, I'm glad this discussion happens, and many such discussions have to happen. I wish Indian Medical Association will take it up seriously, but till that happens, it is lack of awareness, lack of knowledge about available guidelines and available practices, which are practiced only in a minority of institutions. The National Cancer Grid, which has more than 200 cancer hospitals as members, has a guideline very clearly stating among 10 things that should not be done. Do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. That's what they say. But what's happening? So the right process, if that implementation phase means all those doctors are taught how to communicate that. And even if the person, a family member asks, are you not taking him to the ICU? We will, once the explanations are given, usually it is okay. So it is already the guidelines are there, but the lack of awareness and the implementation gap is huge.
You mentioned National Cancer Grid, sir. We have Dr. Ravi Kannan on the line, who's part of that. Dr. Ravi Kannan, your thoughts on how palliative care has been integrated with cancer care, both in your organization and in the National Cancer Grid?
So, uh, the National Cancer Grid aims to bring about uniform quality of care across the country, no matter where the individual is, whether it is Siliguri or Srinagar, they should be able to receive the same quality of care. And that is work in progress. All that we have discussed, several of these initiatives are being, taken up in various institutions in different ways, and it's going to take time, as Rajagopal sir mentioned, to integrate palliative care into the regular oncology care requires activism on the part of the institution's leadership. And so in different institutions, it is at different stages, and it will improve over time. In our institution, we have a very active palliative care service, but many of our physicians who run surgical OP are also trained in palliative care. They've gone through the 6-week course, they've gone through in-house training. Some of them are doing the 1-year course with the Institute of Palliative Medicine. And so we're also trying to see if every patient who needs palliative care is not referred to the palliative care service, that the treating physician himself or herself should be able to take care of most of the palliative care needs.
So thank you, Dr. Ravi. It comes back to what Dr. Rajagopal was saying, that every doctor, every nurse, every healthcare professional should be involved in palliative care, and that's the only way we'll be able to reach everyone there who needs it. Dr. Puneet there was instrumental in actually suggesting this session. So Puneet, you want to add something now?
No, not really. I think it's a very important. I think we need sessions like these. Ravi, I think we need to push them in the surgical oncology and the other oncology sessions as well. For the adult, so we need much more of adult education rather than the thrust only on undergraduates, because if they see bad role models, so I think we need to push it. Like in the last week, we had a Association of Surgeons of India. I was doing a panel on sustainability. I was shocked to realize the level we are abusing, in India. So like that, I think we need to recognize that outside of, some pockets like Kerala and a few cosmopolitan cities and all that, we really need to educate the adults, the teachers before we, who are going to teach the kids. So I think this session like these, we need to, multiply everywhere else. Thanks.
If anyone wants to say anything, please use the electronic hand or turn on your camera so that we know that you would like to say something. Radhakrishna, for your comments.
A very poignant session indeed. But then the thing which we've been discussing in the last hour or so, that the thing that worries me is I always believed that we all are going to die in ICUs, come what may. I can't believe that, with Dr. Rajagopal often on commenting that ICU is not for the terminally ill patients. I don't know where will they go with hardly any, the hospice care. How can have somebody at home who's dying with the lack of oxygen in pain? How can we, how any household will deal with such patients? I really, really am worried about that.
Dr. Radhakrishna, the majority of our patients die at home. Ideally, we should be able to give them enough support. Now, what we are doing is not enough, but we have we educate the family about what's likely to happen. As a matter of fact, somebody whom I have never seen died about an hour and a half back in Chennai. We have been supporting them through both with the internet and with telephone. And there the education of the person happened. And they tackled it at home. But I get your point, especially people who have grown up in nuclear families, have never seen a death. They cannot handle it. So deaths in hospital rooms and in palliative care centers will be the order of the day, not the ICU, where the family can stay, where they will have a hand to hold. That's so important.
So unfortunately, it's the opposite
I
way, sir.
think
Even when the family doesn't want escalated care, when patient is in the hospital and they are in the room, when patient starts becoming uncomfortable, the family pressurizes the patient to be shifted to ICU. It's like, the people in the ICU are used to death. They can handle it, and I don't want to see it. So don't do anything but shift to ICU. That so something like what Radhakrishna is saying. Unfortunately, that happens often. Even if the yes, Chitra.
I think that is why integration of palliative care right from the start is important, because once we start communicating with the family and sometimes even with the patient, who can then make a choice from the beginning. If you start, the decision making at end of life doesn't pose such a challenge. But often what happens is we are called when the patient is in the ICU and asked to communicate or break bad news. So I think if the journey is we are along with them throughout the journey, this decision at that point becomes much easier because the family is much in tune with it and ready to accept it. But that is why that integration is extremely important, that we communicate with them right from the start and give them the realistic kind of picture, not give them false hope or false reassurance.
Dr. Vidya, you realize that this disease of intensive careopathy is only about 25 years old. It's as recent as that. Till the mid-1990s, it never happened. Intensive care was for salvageable situations. How quickly we learned, even the public, they are expecting that all deaths will be in intensive care unit. And that's amazing how quickly the tables turned. So I suppose it'll take many years to bring it back, for the pendulum to swing back, only if we actively keep pushing this.
Dr. Vidya, I'm handing it over to you. It's 9:30. So my responsibility is done.
No. I'd like you to say a few words about what you are doing, and then we'll close.
Me? Let's
Yes.
speak about what I'm doing. Okay. I'm basically trained as a mental health professional psychiatrist, but I got into palliative care in Calicut when I completed my MD psychiatry there. I just got into Pain and Palliative Care Society and worked in palliative care for a long time and still am working. But what I have done is I have kind of transferred principles of palliative care into mental health and the reverse. I have in palliative care, I focus on how to establish or strengthen the mental health aspect in palliative care in terms of emotional support and management of mental health issues. And likewise, we have imbibed the principles of palliative care, long-term care, to treat chronic mentally ill people. So we also run a non-profit organization called Mehak Foundation in the community, where it works just like a palliative care model, but we are providing long-term care for chronic mentally ill patients. And this is in Kerala, based in Cochin, but we have around 25 clinics across 4 or 5 districts. That's in short.
Yeah, thank you. Alka, if you'd like to say something, you've been quite active on the chat box. So if you want to say something, go ahead. You could unmute yourself and speak.
Hi, hello. Thank you for including me in the meeting. And I have a lot of extended family in India, though I'm based in US. And, it is sometimes painful to see the suffering of the people at end of life. I've noticed this a lot in my own family members. So I have a personal interest in trying to develop the specialty in India. So that was the reason for my joining the meeting. And thank you so much for educating me about the status in India. Thank you.
Your closing comments, sir, Dr. Rajagopal.
No, the questions brought out the lack of clarity about the legal position, but even more, what is apparent is that it is going to take many years of active efforts to impart enough communication skills, leading on to discussions about end-of-life care policies and about integration of palliative care into all healthcare. But it's fundamentally a question of accepting the duty of care of a healthcare provider as mitigating suffering. There are enough, Dr. Vidya, I'm sorry I did not mention it earlier. For busy clinicians, there is a MOOC available on our website, massive online open course, so that the modules can be learned at leisure on your own time. That's also available. Thank you. But I'm so glad that this discussion happened. Thank you very much for allowing me to be part of this.
Thank you so much for
Thank-
readily accepting, sir. And I must thank your personal secretary also, who helped to coordinate everything. And thank you, Chitra, for for a nice flow of the conversation and also involving the audience. And as usual, I'm very thankful to the audience for being so interactive. We'll meet again next week with another episode of Marvelous Medicine. If you'd like to be included on the mailing list for the weekly meetings, please send me an email to bidyam@gmail.com. I'm just putting it in the chat box. Those of you are not a part of the list. Thank you.
Thank you so much. Thank you so much for this, and thank you so much for providing an opportunity to, kind of interact with Dr. Rajagopal again. Thank you.
Good night, everybody.
Good night.
Good night.